Welcome to Dr. Sam's anatomy classes. Here we are exploring the intricacies of human body. This question paper of human anatomy is from MJPRU Bareilly. That is Mahatma Jyotiba Phule Rohilkhand University Bareilly of Uttar Pradesh. This university includes 4 medical colleges, 3 private and 1 government medical college. So one is RMRI Bareilly, second is SRMS IMS Bareilly, third is Varun Arjun Medical College Jahanpur, fourth is Government Medical College Budaun Uttar Pradesh. So this question paper of human anatomy is of MBBS first professional exam for 2019 admitted batch. This was a supplementary examination of July 2021, although it was conducted on 4th of August 2021. So this is human anatomy paper second. So paper second, it includes thorax, abdomen, pelvis, lower limbs, systemic embryology, systemic histology, right? So I'll just give you a short preview. This you are seeing is the question paper. It had like 3 parts. Part A is of 20 marks. That includes 20 MCQs, 1 mark each. Then there was this part B, which was of 40 marks, which was of subjective type. Then you have part C. This also was of 40 marks. So that was about this question paper. I'll show you all these subjective questions also later in this video. First, let's solve these MCQs one by one and let me explain you as well. So question number 1 is all are derivatives of septum transversum except falciform ligament, ligamentum teres, coronary ligament or lesser omentum. I hope you can see all the 4 choices. So falciform. Okay, let me write it here. I hope you can see the choices here. And they have asked about all are derivatives of septum transversum except. So first you need to know about this septum transversum. So here I am drawing this embryonic disc. I hope you remember that there is this procaudal plate that develops, and here is a cloacal membrane that develops, and there was a notochord that is being developed here in between, right? And then para-axial mesoderm, intermediate mesoderm, right? If you remember all this, the formed by the splitting of the intraembryonic mesoderm. Then here it's this intraembryonic coelom that develops, and it splits the lateral plate mesoderm into 2 layers. The layer on the periphery is called somatopleuric layer of the lateral plate mesoderm, and here this one is the splanchnopluric layer of the lateral plate mesoderm. And what was being derived here in between was the developing pericardium. This is going to develop into a septum transversum. This will develop into pericardium, and this is the future heart, which actually forms heart tubes initially. So septum transversum, you can see it's being developed in the most cranial portion of the embryonic disc from this cranial most portion of the somatopleuric layer of the intraembryonic mesoderm. Later what happens is that there's this folding of this embryonic disc. There is a craniocaudal folding, then there are lateral foldings. So this, you can imagine this fold, this end goes like this end goes like this, and these 2 folds approach like this. So this is how that gets folded. So later on what happens is that, let's say this is the notochord being developed, right? And from above to this there will be this neural tube which actually will form the CNS, and in the lower portion was this developing gut, which actually is also the continuous with this yolk sac, the secondary yolk sac. And here is this amniotic cavity, right? So this amniotic cavity gets folded on like this. Okay. So now look, what happens is that the cranial most portion I was telling, this septum transversum, because of this folding of this disc, the cranial fold, septum transversum comes to settle down here. It is here that septum transversum comes to settle down, and it will be this heart that will come here, and that heart tube actually it sinks down into this developing pericardium like this. So what happens, what you're seeing is now that septum transversum, which was actually cranial to the developing heart tube, now comes caudal in relation to the developing heart. So up till here, if you've seen this, now let's focus upon the developing gut. If this is the body, there actually is the tube, the GIT that develops, and that gets dilated here, like from the stomach, then the foregut, hindgut, and all. This is the tubes. And you know that in the foregut portion, there is, if like say, let's say this is the anterior and this is the posterior end, right? So this foregut actually has a mesentery attached to the anterior parietal peritoneum. It is also connected behind to the posterior parietal peritoneum, like you have this peritoneum surrounding. But the midgut is only connected to the posterior parietal peritoneum, and the hindgut also is connected only to the posterior parietal peritoneum. So that layer, that posterior layer of peritoneum stays connected. What happens is, you know what, we start giving these different names because of the developing stomach, right? We start giving them different names. In the region of the foregut, right? This is foregut, this is midgut, and this is hindgut. So in the entire length of this developing gut in the abdomen, it is connected posteriorly with the fold of mesentery, while the foregut is connected to the anterior layer of the parietal peritoneum with the help of this ventral mesogastrium. This you call it as ventral mesogastrium, and this layer here is called posterior mesogastrium. Okay, let's draw a transverse section here. So here what you're seeing is a transverse section. Okay, and as I taught you just now that there will be a developing gut here. Let's say this is the developing stomach, and this is the body wall, the abdomen region, which is on inside lined by this parietal peritoneum, and which is connected here with the help of this mesentery. I'm talking about the foregut region, remember, not the midgut, not the hindgut. So that's why we've taken a section from above at the region of foregut. Okay, so this is the posterior thing, and this is the anterior. This is dorsal mesogastrium, and this is ventral mesogastrium. Now what happens later on, the mesenchymal cells, they start collecting down here in the dorsal mesogastrium, the mesenchymal cells, right? This collection of mesenchymal cells will later develop into spleen. And there is also collection of mesenchymal cells here in the ventral mesogastrium. This will develop into liver in future. It will provide the mesodermal component to the liver. However, I'll tell you, from the foregut region, there is endodermal bud, the hepatic bud, which contributes to the endodermal portion. So liver is endomesodermal in origin. Further names to this folds of mesentery, this now you will call as gastrosplenic ligament, and this you will call as linorenal ligament. because behind you have this kidneys placed here. So this is lino-renal ligament. And this fold here between liver and this anterior curvature, which actually forms the lesser curvature of the stomach. So from lesser curvature to the stomach, this will be called as lesser omentum. Now this portion of the ventral mesogastrium, the anterior-most portion, which binds the liver to the parietal peritoneum and to the undersurface of the diaphragm, to the diaphragmatic peritoneum, this will form the falciform ligament. Okay. Now what happens later on, that there is this rotation. This rotation happens like this. So for the further rotation, what happens is this stomach is placed here like this now, right? And it's the spleen placed here, and the liver comes to lie here. This is the liver. Now what you see, what happens is, there was this parietal peritoneum I told you. This was lino-renal ligament. So spleen is a peritoneal covered organ. This is gastrosplenic ligament. Then stomach is covered by peritoneum. Then from stomach till the porta hepatis, till this fold of peritoneum from the lesser omentum to the liver, this is gastrohepatic ligament. It also has a contribution from the first part of the duodenum, don't forget, and that is called hepatoduodenal ligament. So then it lines the liver, it covers the liver. So liver also is a peritoneal covered organ, and at the end, it just towards the wall, anterior abdominal wall to the underlying parietal peritoneum, there is this falciform ligament. Now this portion of the ventral mesogastrium, which binds this liver to the anterior parietal peritoneum and to the undersurface of the diaphragm, that is diaphragmatic peritoneum, there it forms these ligaments. So this ligament, one of the ligament I had just told you, this will form the falciform ligament. And that portion of the liver which is like touching to the diaphragm, the posterior surface of the diaphragm, there also it is, it leaves a gap, and that's the bare area of the liver behind. So posteriorly it spreads and leaves a gap, that's a bare area of the liver, and that's lined by the coronary ligaments. And those coronary ligaments later on terminate in triangular manner, and that's why that's called triangular ligament. So remember now these little points. From the ventral mesogastrium, all what is derived is, one is falciform ligament, then the other is coronary ligament, then triangular ligament, and this is the lesser omentum. So all these four ligaments I have drawn here, these are all derivatives of ventral mesogastrium. Now let me tell you that, talking about this ligamentum teres, this is spleen, there is this liver, and here it's the umbilicus. So in this diagram, what you're seeing, all this is the dorsal mesogastrium, this is gastrosplenic, this is lino-renal, lesser omentum, and there above it is hepatophrenic ligament, that includes coronary ligament, triangular ligament, then anteriorly it's this falciform ligament. And one important thing is that, remember that falciform ligament also carries an artery, and that artery is a branch from the superior epigastric artery. Then remember that this ventral mesogastrium, it also reaches till the umbilicus. And this umbilicus, during the fetal life, you remember the contents of this umbilical cord, there were two umbilical arteries and one umbilical vein. Actually, there are two umbilical veins as well, but the right umbilical vein perishes very early in the fetal life. So what is left is left umbilical vein. So remember, left is left. That means you have only one umbilical vein in the umbilical cord. So that left umbilical vein reaches to this liver like this, which was of course carrying the richest oxygenated blood in the fetal life. So this, this left umbilical vein, after birth, this also perishes. And along with this fold of peritoneum, it shrinks and, it degenerates. And later on, what this forms is called ligamentum teres. Okay. So now let's be back to the question. The question here was, all are derivatives of septum transversum except falciform ligament, ligamentum teres, coronary ligament, lesser omentum. So remember, we're talking about these four choices. And here I have already told you now that ligamentum teres is not a derivative from septum transversum. Actually, this question, derivatives of septum transversum, is not a very well defined statement. Again, I come back to this framing of question, which is not very exactly correct. These are derivatives. All of you just seen in my diagrams. I just explain you that these are derivatives of ventral mesogastrium. All these ligaments except one, because septum transversum is a mesodermal thing, and as I told you that mesodermal cells, they come and collect here in the ventral mesogastrium as well as in the dorsal mesogastrium, but what collects here in the ventral mesogastrium is a part of septum transversum that is going to form the liver. So those cells of the septum transversum, they of course they spread along these different ligaments, but actually speaking, these are derivatives of, the better word you can say is derivatives of ventral mesogastrium. So it's also not a well defined question. So here we come back, your answer will be ligamentum teres, because the ligamentum teres is a derivative of left umbilical vein. Let me write it here because it is a derivative of left umbilical vein. So your answer is ligamentum teres. Next question is question number 2. Question is true about anal membrane. You have to select one correct statement here. Perforates at 6 weeks of intrauterine life. The statement should be complete. Then develops from anterior part of cloacal membrane, lies at proximal part of proctodeum. Now this proctodeum is not correctly written. It is Proctodeum, proctodeum. Not this, the spelling is not correct here. Then it covers the urogenital sinus. Select the correct statement. Now look here, what I'm drawing here is the distal most portion of the developing GIT. That's called the cloaca. This cloaca has an anterior continuation reaching towards the umbilicus. So this is the portion here. This is the portion of the hindgut, and this is allantois. This reaches up to the umbilicus, which later on forms is the urachus. And this portion here is called the cloaca. Now outside to this, of course, in the tail end of the developing embryo, there is this membrane covering from outside, which is ectodermal, right? What I have drawn above is, then the yellow color is endodermal, and the black color thing here, it is this cloacal membrane. This is cloacal membrane, which is ectodermal, right? Now see, what happens is later on a mesodermal tissue starts collecting here in between the allantois and the distal portion of the hindgut, which keeps settling down and compresses this cloaca from either sides. Let me draw a cross section here. Let's see, when you see this cloacal membrane from the under surface, you will find it like this, right? This is cloacal membrane. And let's use this green color portion, green color for the posterior portion, this green color I'm using is for the posterior portion. Now look what happens. This blue color thing is the mesodermal tissue which collects here on the two sides and starts compressing. It compresses this cloaca from the two sides, and also it settles down from above like this. So what happens later on is this is called uro-rectal septum. This uro-rectal septum will now descend down and will split this cloaca into two tubes. The anterior tube, which was continuing up till the allantois, this is called now as urogenital sinus, the primitive urogenital sinus. And as I told you that the green color was for the distal portion of the tube of the cloaca, and that is going to form the rectum, the distal most portion of the posterior most portion of the cloaca, that forms the rectum. And here it was this uro-rectal septum, right? And as I told you before that this cloacal membrane was here like this, and there's a ridge developed and it splits into two. Now the cloacal membrane is also going to split into two, and now this portion onto the portion of the urogenital sinus, the primitive urogenital sinus, which is resting onto the anterior portion of the cloacal membrane. This is called urogenital membrane. And this portion, the hindgut, the rectum, which rests onto this posterior surface of this cloacal membrane, is called the anal membrane. So that's how now you're seeing is this cloaca has been divided by this uro-rectal septum into two tubes. Anterior one is now the primitive urogenital sinus. Posteriorly, it's the rectum. And rectum terminates in the form of anal canal. When it reaches the urogenital membrane, now here it will be covered by this membrane, and this is called anal membrane. And here this cloaca will be covered on outside by a membrane that is called urogenital membrane. I hope you've understood now. And of course, you know that at this junction where this allantois and hindgut that join, there was this opening of the mesonephric duct, which actually will form the future ureteric, which will give rise to a ureteric bud, and will also form future the ejaculatory tubes, the duct, the vast difference in the ejaculatory ducts, as well as the ureters, because this primitive urogenital sinus is going to form the urinary bladder as well as the prostatic urethra and the phallic urethra. Look here, one more thing when I'm talking is about the developing fetus, right? So remember, at this anal opening, there is a depression created here, and of course a depression created here, and in between is this GIT that develops like this. It is endodermal, right? So the depression created at the cranial end, this depression created here is called the stomatodeum. Similarly, the depression created at the terminal end is called proctodeum. So this proctodeum, if you see, it's a depression of this surface ectoderm like this. And here the green color, remember the anal canal, the rectum, and here is the anal membrane. This is anal membrane. And now this is called proctodeum. So one thing is clear that this proctodeum, when it is its invagination of the surface ectoderm at the anal opening, that's anal pit. So anal membrane, you can see, is being formed at the proximal end, right? The proximal portion of the proctodeum. Now let's back to the question. This question here is about anal membrane. It perforates at 6 weeks of intrauterine life. So this is the theoretical part. You have to remember this, that it's not the 6th week. It is actually the 9th week. It's the 9th week of intrauterine life when this anal membrane perforates. So this becomes a wrong statement. Then they've written is develops from anterior part of the cloacal membrane. Here, look on this diagram here. This diagram. Cloacal membrane is this, like, which is lining, ectodermal lining on the intersurface of the primitive urogenital membrane. Now later on it splits. So remember now what anterior portion of this cloacal membrane is forming the urogenital membrane, while the posterior portion of the cloacal membrane forms the anal membrane. So that means this also becomes a wrong statement. Then choice C is it lies at proximal part of the proctodium. Yes, you can see it here, that here I had shown you that this is proctodium in this diagram I'm talking about. So this proctodium on its proximal means inner surface, it's lined by anal membrane, which actually ruptures at the 9th week of intrauterine life. Next choice here is it covers the urogenital sinus. So urogenital sinus is a primitive term. Later on it splits into two portions, into primitive urogenital sinus anterior and posterior is the rectum by the uro-rectal septum. So saying that anal canal covers the urogenital sinus is not the correct statement, because it is the urogenital membrane. It's the urogenital membrane that covers the urogenital sinus. So that also is a wrong option. So what remains is the correct choice here. You can mark here that true about anal membrane is that it lies at the proximal part of the proctodium. This will be your answer. Now question number 3. Fibrocartilage is found in costal cartilage, nasal septum, intervertebral discs, auditory tube. It's an easy question. You should know all the types of cartilages and the examples. Less of space here, so I'm not mentioning all of the examples because I've already posted all the examples in earlier one of my series in this question paper solutions. You can check out from there. Right now, just remember that costal cartilage is a hyaline cartilage, nasal septum again hyaline cartilage, intervertebral discs is a fibrocartilage, auditory tube is an example of elastic cartilage. So the answer here will be intervertebral discs. Question number 4 is panniculus adiposus is seen in scrotum, orbits, eyelids, penis. This question is a repeated question. This was being asked earlier in 2014 in FMGE exam, which was conducted by AIIMS New Delhi. This, I should say, is again not a properly framed question, because panniculus adiposus, panniculus carnosus, these are all terms related to the thin sheet of muscle and fat surrounding the body, and this is actually related, this panniculus adiposus, this word is like related with the lower animals. They shiver their bodies, so the skin, there's a wave of contraction along the skin, so as to repel the stimulus. So that's what I'm telling. That was panniculus carnosus, thin sheet of muscle underlying to the skin, subcutaneous muscle. And remnant, let me write it down. Panniculus carnosus. This is a subcutaneous thin sheet of muscle surrounding the body, which is much more prominent and well developed in lower animals. But in us, in human beings, this sheet of subcutaneous muscle actually is present on the face, and all the muscles of facial expression are actually a remnant of these panniculus carnosus. Now, talking about panniculus adiposus, this again is another term for the subcutaneous fat or adipose connective tissue surrounding the body and giving body its shape. It's like packing the body from all the sides. Then this also is, it's actually what they have asked is seen in, right? So let me tell you that the purpose of this question, that the mean is where do you actually find in, or to know that there are 3 options here where you don't find this adipose connective tissue. So one, is in scrotum there is no fat, and in eyelids also there is no fat, and in penis also there is no fat underlying to the skin. So these are the sites we do not find subcutaneous adipose connective tissue. Now orbit, as the answer here is orbit, it's the answer here, orbit. But because you have fat in the orbit surrounding the eyeball, but that is not a subcutaneous fat, because this developmentally there is this orbital septum which separates this the contents of the eyeballs separated from this subcutaneous tissues. So later on that orbital septum splits to form palpebral fissure, and also the the fat within the orbit is also not a part of panniculus adiposus. Panniculus adiposus means subcutaneous fat. So the answer, no doubt here, because ruling out the other three options, the answer becomes orbit, but it is not a satisfactory answer. Okay, next let's move to question number 5. All of the following lie between the first rib and the apex of lung except superior intercostal artery, thoracic duct, first posterior intercostal vein, sympathetic trunk. I believe you've understood what they mean to ask here. This, you can presume, I have drawn is the manubrium, right? And from there you find is this the first rib attached, both the sides, like this. And of course you have this vertebrae here, the first thoracic vertebrae, and it's here you find is the lungs, the apices of lungs, both the sides. It's the apices of the lungs, both the sides. The apex of the lung encroach into the root of the neck or the base of the neck and reach up to the transverse process of the C7 cervical vertebrae, covered by substance fascia or pleural suprapleural membrane. What they're asking is all of the following lie between first rib and the apex of the lungs. So remember that superior intercostal artery. The superior intercostal artery is a branch of costocervical trunk. Now this, because costocervical trunk is a branch of second part of the subclavian artery, which is above the first rib. So the superior intercostal artery descends down from the neck to reach into the thorax like this. So you can presume that this is superior intercostal arteries, which provide first and second intercostal arteries. Now thoracic duct, that thoracic duct ascends initially on the right side of the spine while entering into the thorax from the aortic opening in the diaphragm right side of this abdominal aorta, and at the level of the sternal angle, that is T4, T5, at the level of fifth thoracic vertebrae, it moves towards this left side, crossing the spine anteriorly, and then in the superior mediastinum, thoracic duct ascends onto the left side of the spine, and it crosses the thoracic inlet and reaches up to the transverse process of the seventh cervical vertebrae. And also remember that thoracic duct becomes a content of carotid sheath on the left side. Then of course it drains at the junction of this internal jugular left side and left subclavian to drain into the left brachiocephalic vein. So you have this I have drawn is thoracic duct on the left side. First posterior intercostal vein. Now remember that first posterior intercostal vein, actually, now look here, you must be knowing about this, that this is the right brachiocephalic vein, this is the left brachiocephalic vein. Together they form the superior vena cava, and the superior vena cava receives a tributary on the right side, and this is azygous vein. Here it is this accessory hemiazygous vein, and here it is this hemiazygous vein. So remember that first posterior intercostal vein drains directly into this brachiocephalic vein, and then you have is first, second, third, the join and the drain into this brachiocephalic vein on the left side, and this was 1 to 4, then you have 5th, 6th, 7th and 8th. 5 to 8 intercostal veins on the left side drain into this accessory hemiazygous vein, and then 9, 10, 11, and 12th. This is 9 to 12 left posterior intercostal veins, including the 12th one we call it a subcostal vein. They together drain into this hemiazygous. Now on the right side, this is the first posterior intercostal vein that drains directly into the right brachiocephalic. Then you have second, third, and fourth right posterior intercostal veins that drain into the azygos, forming this vein called right superior intercostal vein. And then you have 5th, 6th, 7th, 8th, 9th, 10th, 11th, and 12th. All these right-sided posterior intercostal veins, they drain into the azygous vein. So if you have got to know about this, now come back to the question that you know about this relationship. I have already been telling you many times. Now look here about this relationship here. What I'm drawing here, it is this manubrium sterni. Remember, this relationship is very important. It has been asked several times. And this is the sternum. So I've been telling that the immediate relation of manubrium posteriorly in its upper half is the left brachiocephalic vein, and in the lower half it is this arch of aorta. That is a content of superior medial sternum. And you also know that the first rib passes like this, right? So you've got to know that this first posterior intercostal vein, it does not need to cross the thoracic inlet. It is this internal jugular vein and subclavian veins, this internal jugular and the subclavian veins, both the sides. It is these veins that cross the thoracic inlet. Or you can say even the junction, the brachiocephalic might be seen at this just junction behind to this sternoclavicular joint, because above you have is the clavicle placed here like this, right? So just behind to the sternoclavicular joint, you find is the junction of the two veins to form a brachiocephalic vein. So remember that this first posterior intercostal vein is not seen between the apex of the lung and the first rib, because it's a content of superior medial sternum. While talking about this sympathetic chain, it crosses here at the head, just in front of the head of the ribs, or just in front of the neck of the ribs, right? Just there you find, in between the first ribs and the apex of the lungs. So it's very clear now that your answer should be first posterior intercostal veins here. Next question is, inferior vena cava obstruction presents with esophageal varices, hemorrhoids, paraumbilical dilatation, thoraco-epigastric dilatation. So remember that what I'm drawing here is this trunk, right? These are the limbs, and here you have is the umbilicus, and here you have is the heart. I'm drawing it in blue because we are talking it about the venous circulation. So here it is this inferior vena cava. Now when there is obstruction in this inferior vena cava, what will happen? So blood will not be able to enter into the right atrium from below. So what happens is this has to take a different course to reach to the superior vena cava. Now what happens is that this inferior vena cava at the level of L5, it divides into right and left common iliac veins. These common iliac veins soon divide into external and internal iliac veins. Now external iliac vein continues as femoral vein after crossing this inguinal ligament, right? Okay. Now this femoral vein, through this, remember that saphenous opening cribriform fascia, from there it sends this superficial vein towards the umbilicus, running in between fascia of Scarpa and fascia of Camper. Now this vein is called superficial epigastric vein. Now the superior epigastric vein will now communicate above. Now look here, what was we're talking here is about this SVC. Now SVC was having this azygos as one tributary, then it was dividing into right and left brachiocephalic. Brachiocephalics actually are formed by the joining of this internal jugular and subclavian, right? And now remember that subclavian continues as axillary vein. Now in axillary vein, there was this lateral thoracic vein. Now this lateral thoracic vein descends down here like this. This is lateral thoracic vein. This lateral thoracic vein gets communicated to the superficial epigastric vein like this. Now this, remember what I've told you, is lateral thoracic vein, and this is thoraco-epigastric vein. So this thoraco-epigastric vein is actually not a continuous, regular blood supply. It's not a regular pathway of circulation. It is a patent vein. Just like, remember, there are parambilical veins, the esophageal varices, and different other venous circulation which actually become patent in certain hypertensive conditions. So similarly, thoraco-epigastric vein is not a patent vein in regular life, but in such conditions where there is inferior vena cava obstruction, there will be a reverse circulation of blood. So this reverse circulation of blood will be just keep on following what I'm saying because there's less of space. So now what will happen in superior vena cava obstruction, blood will go back downwards from IVC to common iliac vein to external iliac vein to femoral vein to superficial epigastric vein. Then through the thoraco-epigastric vein, it will reach this lateral thoracic vein, then axillary vein, subclavian vein, brachiocephalic vein, superior vena cava, and will reach into the heart. So that is a reverse circulation, and again the reverse will happen if there is obstruction of superior vena cava. So the blood will descend down from above and will reach into the heart through the inferior vena cava, and this will be happening bilaterally, both the sides. So what happens is, like in a subject, when you'll see that on a subject, you will find that if this is the trunk and here is the umbilicus, so you will find that these superficial veins will be seen, like, because it's not a single vein, there are a lot many tributaries and ramifications. So on the surface of the body, you will find such longitudinal veins become tortuous subcutaneously and they will be visible. So that is going to happen in case of inferior vena cava obstruction. And one more important thing, that remember, you have this watershed line here. This you call as watershed line, which means that the venous circulation and the lymphatic circulation above and below the umbilicus do not meet. Means this venous circulation above, venous drainage or lymphatic drainage of the umbilical will reach above, will drain into the veins above, and the veins and lymphatics below to the level of umbilicals will drain to the veins and lymphatics below. So there is this watershed line. This is called watershed line. This is followed in regular circulation as well as in the caput medusae being formed by this portal hypertension. There also this watershed line is being obeyed. But in IVC and SVC, this IVC and SVC watershed line is breached. So this is not followed. This watershed line funda is not followed in case of this IVC. In case of IVC obstruction, the circulation will be like this. This is IVC obstruction. In case of SVC obstruction, the circulation will be from above downwards like this. So the watershed line is breached in SVC and IVC obstruction. It is followed in case of portal hypertension, and that's called caput medusae formation, where this watershed line is obeyed. I hope you understood. So this esophageal varices, hemorrhoids, and parambilical dilation all are a feature of portal hypertension. And inferior vena cava obstruction will present with thoraco-epigastric dilatation. So your answer becomes D. Question number 7. Subcostal nerve is dorsal ramen of T6, ventral ramen of T6, dorsal ramen of ramus of T12, ventral ramus of T12. This is a very easy, simple type of question. You know that this spinal cord actually gives out its two roots, a ventral, that is a motor root, and dorsal, that is a sensory root, with a ganglion here called DRG, dorsal root ganglion. Together they form this nerve called spinal nerve, which after emerging out from the intervertebral foramen, remember, in case of cervical nerves, they emerge out from the numerically corresponding cervical vertebrae above to that vertebrae, and from thoracic downwards these spinal nerves will emerge out from below to the numerical corresponding vertebrae. So this is spinal nerve. This spinal nerve, after emerging out, soon divides into a dorsal primary ramus and a ventral primary ramus. So dorsal primary ramus splits soon, it reaches back to supply the muscles and the cutaneous innervation on the back, and will split here and will pierce the deep fascia and will supply the skin by its cutaneous branches. Now this is the ventral primary ramus. So ventral primary ramus continues like this anteriorly, and in its mid-axillary line it gives its cutaneous branches here like this to supply the lateral trunk, and this anterior continuation of the ventral primary ramus again pierces the deep fascia to give out its anterior cutaneous branches like this. So talking about, and these ventral primary ramus, they enter between these ribs to form the intercostal nerves, or thoraco-abdominal nerves. The lower six thoracic nerves, they actually also supply the abdominal wall, so that's why they call thoraco-abdominal nerves. So all of these nerves are actually this ventral primary ramus. These nerves are actually the ventral primary ramus. So when we talk about subcostal nerve, intercostal means between the ribs, and you know that the T12 nerve actually will have no nerve, it will have no rib below, like you don't have 13 ribs. So this 12th thoracic nerve is called subcostal nerve. So remember, your answer here should be ventral ramus of T12. Okay, so the next question is, septum secundum arises from bulbus cordis, primitive ventricle, primitive atrium, sinus venosus. Now for this, I think I have to revise this development of inter-atrial septum for you so that it becomes easy to understand. Now keep following. You know what I'm drawing here is, let's say this is the two atrial chambers. I'm drawing it like 3 consecutive chambers so that you can see the differences that's being happening. Here you find is the cushion being formed. This is endocardial cushion, like this, endocardial cushion. Then, and the other things which are already being formed, let me draw here. It was this septum spurium being developed, and then it was this sinoatrial orifice being developed here in this right atrium. You know what, all these events are happening. It is the 5th week of intrauterine life. Remember that. Now, by this, beginning of this 4th week of intrauterine life, what happens is there is this formation of septum primum. Now this septum primum is actually formed by this folding of a groove being formed on the outside by the 2 atrial chambers, and from the primitive atrial chamber, the dorsal wall, there is the septum being developed. It is actually crescentric in shape, and this, let me write it here, it is septum primum. So this develops down and it grows downwards towards this AV cushion or endocardial cushion, the red color thing, which we also call as septum intermedium. Let me write it here also. This is septum intermedium. So we have 3 septum, remember, this is the septum intermedium. Now with course, this event was happening, the first one I've drawn is happening at the 4th week of intrauterine life. Now gradually this will develop, its crescentic thing with a sharp margin below. It will approach towards this endocardial cushion, and then here it leaves a gap. That gap formed here is called, this gap here is called foramen primum. It's at the lower edge of this inter-atrial septum. Now because when it grows and approaches towards this endocardial cushion, it joins here, this crescentic margin, it joins here at this lower end. At the same time, what happens is it gets detached from its upper end. The reason being, there has to be some opening, because the blood circulation is from right to left atrium. So if that's the septum primum gets obliterated, there has to be a passage for the circulation. The blood circulation was like this. Later on, the blood circulation was like this. So now, after closure of septum this foramen primum, there is formation of this opening, and this is called foramen secundum. This is foramen secundum. Okay. Then what happens is, I have already drawn this sinuatrial orifice, this septum spurium and sinuatrial orifice. This has to be drawn in so that you clearly understand. Now what happens is, there is another septum that starts developing on the left side of this septum spurium and sinuatrial orifice, and this septum is also being developed from the primitive atrium. This also gradually descends down and approaches towards this endocardial cushion. So what is going to happen next here, just see here, this will gradually diminish out, right? So there will be this opening left here. The opening was foramen secundum. Now with the formation of this septum secundum, which descends down and with a sharp crescentic margin, it reaches on the right side of this septum primum like this, so as to close this opening, this foramen secundum from the right side. So the gradually a little space is left for the flow of blood like this. So it's actually a valvular mechanism which is unidirectional. So the blood flow can only be from the right atrium to the left atrium. This is how it is being formed. Now, after birth, what happens is, this after being formed, this flap-like septum secundum, let me write it here. This is yellow one is septum secundum. And after this has reached this limit and this valve is formed, this is called foramen ovale. Okay. After birth, everything, because the pulmonary circulation has been established, so what happens is this closes. There's a closure of this foramen ovale, and what will be left out is a shallow depression, and that is called fossa ovalis. And the sharp crescentic border of this septum secundum, which forms the lower margin of this foramen ovale, that is called annulus ovalis. So remember that septum secundum arises from the primitive atrium. Next question is, okay, let me tell you that there was this pulmonary veins also being developed here by this time of formation of inter-atrial septum. There was this pulmonary veins also being developed in the dorsal wall of this left atrium. Pulmonary vein. Now question number 9. Pulmonary veins develop from 6th aortic arch, primitive left atrium, left common cardinal vein, left vitelline vein. So like I previously told you in my question above, that this was the two atrial chambers being formed, and how this inter-atrial wall was being formed, I've already told you. Now what happens is that in the dorsal wall of the left atrium, there is this primordial pulmonary vein that is being formed by the outpouching of the primitive left atrium. So when this outpouching happens, there is actually a single vein coming out like this. Now what happens is, let me draw it here like this. This is the wall of this left atrium, and here it is this pulmonary vein that is arising. So it actually divides now into two branches like this. And then later further it divides into another two branches like this. Gradually in the course of development, now you see that this much portion I've drawn in green color, this all is going to be get absorbed and incorporated. The green color portion of this primordial pulmonary vein, it will get absorbed and will contribute to the development of the posterior wall of the left atrium. So what will happen next here, you can see that it will be something like this. This is how you will find that it's the posterior wall of the left atrium. So remember that this, due to the absorption of these pulmonary veins, there is this post dorsal wall of the left atrium which forms a smooth musculature. So the smooth portion of the primitive left atrium is formed by the absorption of the pulmonary veins, primordial pulmonary veins. So answer here also will be primitive left atrium. Question number 10. Peroneus longus is an inverter of foot supplied by deep peroneal nerve, maintains arches of foot, arises from tibia. So remember that peroneus longus is a muscle of the lateral compartment of the leg, and it arises from the lateral surface of the fibula above to the origin of peroneus brevis. And it is through this muscle, that is this common peroneal nerve, divides into deep and superficial branches at the neck of fibula. Now, this peroneus longus passes behind to this posterior surface of the lateral malleolus through this peroneal retinaculum, the above one, which is combined retinaculum, then down below that the two retinaculum that separates out because of the peroneal trochlea. So through that inferior portion of the inferior peroneal retinaculum, peroneus longus now moves on the lateral side of the foot, grooving this bone, tarsal bone, cuboid. On the undersurface of the cuboid, it grooves the cuboid and moves towards the medial side on the plantar aspect, forming the muscle of the fourth layer of the sole, and gets inserted on the medial cuneiform and the base of the first metatarsal at the same site where tibialis anterior is being inserted, which is coming from the medial side. Together, the two muscles, tibialis anterior, peroneus longus, they form a sling which help in maintenance of all the arches of the foot, especially the posterior transverse arch. I explained this, and if you have studied this muscle, you would have understood what I have mentioned just now. Now let's focus upon the options. So it's an inverter of foot? No, it's an everter of foot. Supplied by deep peroneal nerve? No, it is supplied by superficial peroneal nerve or fibular nerve. So international publishers, they write it as superficial and deep fibular nerve. Then maintains the arches of foot. Yes, of course, it maintains the arches of foot. It arises from tibia. No, it arises from fibula, lateral surface. So remember that it maintains, alone itself, it maintains the lateral arch of the foot as well as the posterior transverse arch of the foot. But together with tibialis anterior, it forms a sling, and then it will maintain all the arches of the foot, because if you talk about the sling, otherwise talking alone maintains, peroneus longus will maintain three arches: the lateral longitudinal arch, the posterior transverse arch, and the anterior transverse arch to a little extent. So your answer here is it maintains the arches of the foot. Question number 11. Trendelenburg test is positive due to injury to the nerve, inferior gluteal nerve, superior gluteal nerve, obturator nerve, tibial nerve. It's a very easy question. Trendelenburg test is for the abductor mechanism of the hip joint. Superior gluteal nerve, it supplies three muscles. Remember, gluteus medius, gluteus minimus, and tensor fasciae lati. And this nerve, superior gluteal nerve, runs between gluteus medius and minimus, between the inner two muscles, not between maximus and medius. Remember this. So because of the injury of this superior gluteal nerve, there is paralysis of these muscles. So because these muscles are very powerful abductors of the hip joint. So when a person walks, like lifting his right foot off the ground, it is the left gluteus medius minimus that contracts to tilt the pelvis on the left side, thereby lifting the right foot off the ground. So if this is paralyzed, what happens is when a person tries to lift his foot up and place it in front, the pelvis on that side droops down, and that causes limb lengthening, and that's where the person will have to sweep his leg in a circular manner to place it in front, and that will bring a lurching gait on the left side. And if this happens bilaterally, then the gait will be a waddling gait. So the answer here is superior gluteal nerve. Question number 12. Gluteus maximus is inserted on lesser trochanter, greater trochanter, spiral line, ilio-tibial tract. It's an easy question. Remember, the gluteus maximus is a wide origin. It takes origin from the iliac crest posterolaterally, from the posterior 1/3, from the posterior superior iliac spine, then the posterior surface of the gluteal surface of this iliac bone on outside behind this posterior gluteal line. Then it also takes origin from the lateral surface of the sacrum, lateral surface of the coccyx, and also from this superficial surface of this sacrotuberous ligament. This is a big origin of this muscle, and it winds around laterally and that get inserts onto the iliotibial tract. Iliotibial tract is a thickening of the fascia lata of the thigh. It's connected right from this iliac crest, invests this muscle tensor fasciae lati, and descends down and reaches and inserts onto the anterior surface of the lateral condyle of tibia. So onto this iliotibial tract, there is insertion of gluteus maximus, the most of the superficial fibers. However, there are few deep fibers they insert onto the posterior surface of the femur below to the greater trochanter, and even below to the quadrate tubercle you find is a tuberosity, and that is gluteal tuberosity. So the deep fibers of gluteus maximus insert onto the gluteal tuberosity. The superficial fibers they insert into the iliotibial tract. Question number 13. Abduction and adduction of foot occurs at which joint? Ankle joint, subtalar joint, tarsometatarsal, and transverse tarsal. Now look here, ankle joint is a hinge joint. So there is only movement possible in a single plane, that is dorsiflexion and plantar flexion of the foot. Right? Now adduction and abduction, this will happen at the subtalar joint, that is also called as talocalcaneo-navicular joints. So at this point, abduction and adduction also happens, as well as it also contributes to the dorsiflexion and plantar flexion. Together involving these four movements, we also call it as inversion and eversion. So actually inversion and eversion is a combination of dorsiflexion, plantar flexion, adduction and abduction. That's together leads to inversion and eversion. And these movements are happening at the subtalar joint. So remember, adduction and abduction, this will happen at the subtalar joint. Now this question is question number 14. All are contents of femoral sheath except femoral artery, femoral nerve, femoral vein, genitofemoral nerve. I think I've already explained this earlier many times. It's better to revise each time. This is the inguinal ligament, right? And from this pubic tubercle, laterally there is this sheath formed, and this sheath anterior wall is being formed by the fascia transversalis, and the posterior layer of this sheath is being formed by the fascia iliaca, and this sheath descends down like this. So, and this is also compartmentalized like this. So from the lateral compartment of this femoral sheath, it is this external iliac artery which continues down as femoral artery below to this point called mid-inguinal point. Then in the middle compartment, there is this external iliac vein, femoral vein actually ascends to continue as external iliac vein from this compartment. And you must have heard that in the middle compartment, there is this lymph node, also called lymph node of Cloquet or lymph node of Rosenmuller. So this canal, the medial most canal, this is called femoral canal. And the sheath I had drawn here, the sheath is called femoral sheath. And remember, what is femoral ring? So the opening of this femoral canal above, that is called femoral ring. Another important fact is that this femoral ring, the medial boundary of this femoral ring, has an important ligament which is actually a horizontally placed ligament which is crescentric, and that is called lacunar ligament. Now there's one nerve also which passes into this sheath, and that pierces this lateral compartment and then emerges out to become cutaneous and supply the skin of the roof of the femoral triangle. So this nerve which accompanies this femoral artery in the femoral sheath, this nerve is femoral branch of genitofemoral nerve. However, what stays out of this sheath is femoral nerve. Now this femoral nerve actually passes below to this point on the inguinal ligament, that is called midpoint of inguinal ligament. So if you understood now what the consists of femoral sheath, except the answer will be femoral nerve. Question number, now this is question number 15. Which of the following structures pass through adductor magnus? Options are femoral vessels, femoral nerve, femoral sheath, saphenous nerve. So I think I have to draw this diagram for you. Now look here. Talking about adductor magnus, you know it's a hybrid muscle. It belongs to two compartments, medial compartment and the posterior compartment of the thigh. That means it has both the functions of adduction of thigh as well as extension of the thigh at the hip joint, because that's a part of hamstring. So you know this portion here, this is called the ischial tuberosity. So it arises from the lower outer portion of the ischial tuberosity, and it also takes origin from this ischiopubic ramus. So the portion of the muscle that takes origin from ischiopubic ramus, these fibers, remember, they will run horizontally or obliquely to get inserted into the upper portion of the linea aspera, like this. Now the fibers which were arising from this ischial tuberosity, these fibers are hamstring fibers, and they will descend down nearly vertically to reach down in the lower half of the linea aspera, and ultimately the last end that they join is this point here. This point here is called the adductor tubercle on the medial condyle of femur. So remember, there can be lot many questions framed on this adductor magnus. Horizontal fibers means we're talking about adductor fibers or fibers arising from ischiopubic ramus. Vertical fibers means fibers arising from the ischial tuberosity, right? And you can even think about the purpose also. The action, obviously, these fibers will contract like this, and these fibers will contract like this. So adduction is a purpose of fibers from pubis, and extension at hip will be a purpose action of those fibers arising from the ischial tuberosity. Now talking about this muscle has perforations at the point where it attaches on the linea aspera. It has minute 4 perforations like this, and a major perforation here at this level of adductor tubercle. and this is called hiatus magnus. So now look here on the posterior aspect. Now with this diagram I am drawing here is the right femur posterior view. This is the right femur posterior view. I have drawn it like this. So on the medial lip of this linea aspera, this muscle that takes origin is vastus medialis, and laterally the lip provides origin to vastus lateralis. Then there is insertion here of pectineus. Then you have adductor longus, and the gap between the two muscles is filled by this muscle adductor brevis. So this is pectineus, this is adductor longus, and this is adductor brevis. Then there is a wide insertion of this muscle. This muscle is adductor magnus. This linea aspera also provides origin to one muscle. This muscle is the short head of rectus femoris. And I've already told you there are minute perforations here in this attachment of adductor magnus and the wider opening here. So now look at the course, because they've asked us what are the structures that pass through adductor magnus. So it is this femoral artery which is descending down like this, passing out through this hiatus magnus. This is femoral artery. Okay. Now femoral artery gives its branch laterally called profunda femoral artery, which is the largest and the longest branch of femoral artery. This profunda femoral artery from this, in the femoral triangle, it descends downwards medially and crosses pectineus, and then in the gap between pectineus and adductor longus, it moves down like this. It has this course. Now what happens is this profunda femoral artery gives out its 4 perforating branches like this. So the key muscle in the back of thigh is said to be this adductor brevis, because the 4 perforators you can learn easily. The first perforator you've seen that crosses the upper margin of adductor brevis. The second perforator pierces this adductor brevis, and the third perforator at the lower margin of adductor brevis crosses adductor magnus, and the fourth perforator is at the equidistance, and the profunda femoral artery itself terminates after perforating this adductor magnus through the minor openings. And all of these muscles there, you can see they are reaching to perfuse this wide, big, bulky muscle called vastus lateralis. Now talking about the other structures which pass through this adductor magnus, one is femoral vein. Now this femoral vein actually, it also descends like this, and this crosses behind this femoral artery. So this is femoral vein. Now femoral vein emerges lateral to the femoral artery by emerging out of hiatus magnus. One of the other choices they've mentioned is saphenous nerve. So remember that saphenous nerve is a branch arising from the posterior division of femoral nerve, which actually is cutaneous for the leg and the foot, but it is a deep nerve when it's in the thighs. So there's saphenous nerve also emerging out like this, running in this adductor canal and emerges out like this. In case they ask what is the the last branch of femoral artery, because after this femoral artery emerges out of the hiatus magnus, it will now be called as popliteal artery. So if it's asked what is the last branch of femoral artery, remember there's a branch given out from this femoral artery in the adductor canal, and that is called the descending genicular artery, which also gives a twig to run along with the saphenous nerve, and this is called saphenous artery. This was hiatus magnus, right? So what have you concluded from this now? The question is, which of the following structures pass through adductor magnus? So let's see the choices here. Femoral vessels. When talking about femoral vessels, we mean femoral artery and femoral vein. You have seen that both these vessels are passing through adductor magnus through the hiatus magnus. Femoral nerve, of course, does not passes through adductor magnus. Femoral sheath has nothing to do with this adductor magnus. I have explained about femoral sheath in the earlier question. Now, saphenous nerve, yes, you have just seen that saphenous nerve also crosses this, passes through this adductor magnus at the hiatus magnus. Otherwise, there is the four perforators from profunda femoral artery, they also pass through adductor magnus. So, because I guess the answer A and D are equally correct. So, this question is a wrongly framed question. It's a wrong question. And that's why all the students who have attempted or who haven't attempted, they all should get +1 for this. Question number 16. Sensory nerve supply of gallbladder is through vagus nerve, phrenic nerve, sympathetic nerve, splanchnic nerve. So now remember that this gallbladder, this is the hepatic duct and this is the cystic duct, and it joins to form this common hepatic duct. Now, talking about the nerve supply, there's this artery reaching down to supply this cystic artery, which is a branch of the right hepatic artery. The nerve fibers, nerve supply to a viscera reaches along the blood vessels. So this area of the gallbladder, which is the territory of the nerve plexus around the cystic artery. So this is called cystic plexus. This cystic plexus is actually derived from this plexus, the hepatic plexus. And this hepatic plexus is derived from the plexus along the celiac trunk. So this is derived from celiac plexus. And in celiac plexus there is contribution from splanchnic nerves, and those are actually sympathetic fibers from T7 to T9 through the greater splanchnic nerves, both right and left, and of course vagus, contribution from vagus. There's also nerve supply through phrenic nerve. Phrenic nerve also reaches to supply the gallbladder of the right side. Now, the three nerves, they are all approaching this gallbladder through these routes. And talking about the sensory nerve supply, remember that sensory nerve supply of the gallbladder is through all the three components. If the sensory nerve supply is being pursued by vagus, the pain will be referred to the area of the stomach, and that's called epigastric region. Epigastric fossa. Then phrenic nerve. If the pain of gallbladder is perceived through phrenic nerve, this will be referred to the right shoulder. Let me draw it here so that you can remember it for a long time. Okay. Gallbladder is here. It's the gallbladder here. And its pain will be referred to this area, that is the epigastric area, and this will be through vagus. If the pain is being perceived through phrenic nerve, then the referred pain will be at this shoulder, on the right shoulder. Remember, phrenic nerve is C4, C3, C4, C5. So that C4 also perceives somatic pain from the skin overlying to this shoulder on through the supraclavicular nerves. So this is the shoulder, right shoulder, and the pain, the referred pain here will be through phrenic nerve, right phrenic nerve. Now, if the pain is being perceived through sympathetic fibers, the pain, it's exactly talking its T7 segment. The lateral horn of the T7 spinal segment gives out those sympathetic fibers which actually reach to the gallbladder. So, if the pain is being perceived through the sympathetic fibers, the pain will reach this T7 segment, and the T7 segment also receives somatic pain from this area of the scapula at the inferior angle. So if the pain is here at the inferior angle of the scapula on the right side, inferior angle of right scapula, that means the pain is being referred by sympathetic fibers, and those sympathetic fibers are being carried by the splanchnic nerves. So we back to the question. Sensory nerve supply of the gallbladder is through vagus nerve, correct. Phrenic nerve, correct. Sympathetic nerves, correct. Splanchnic nerves, also correct. So this question is a wrongly framed question, and all the students who have attempted or who have not attempted, they all should get +1 marks for this. Talking about question number 17, Caloid's triangle is formed by all except inferior surface of the liver, common hepatic duct, cystic artery. So imagine this is the liver, right? This is the liver. This is the inferior surface of the liver. This is the right hepatic duct and the left hepatic duct. Together they join to form this hepatic. Actually, these are deep inside, so let's not draw it here. You can cover it inside because it's all behind to this inferior surface. So it is actually the hepatic duct here. So this hepatic duct, and to this hepatic duct, it is this gallbladder attached like this with this cystic duct. So this is gallbladder, and then there it is this common bile duct. Now can you see the triangular space left out here? This triangular space is called Caloid's triangle. So let me do the labeling for you. This border is being formed by the inferior border or the inferior surface of liver, and here it is this common hepatic duct, this boundary, and this is being formed by cystic duct. So that's how a triangle formed. This is common bile duct. Now talking about the all except. So remember, and the arterial supply, this artery, the proper hepatic artery, gives its branches which run along these hepatic ducts. So the right hepatic artery gives a branch to supply the gallbladder. So this is called the cystic artery. Cystic artery arising from the right hepatic artery. There's one more thing you can appreciate in case for your future, if they ask something relevant to this. There is also a lymph node placed here. This lymph node is called the lymph node of LUND, lymph node of Lund, or cystic lymph node. So back to the question, Caloid's triangle is formed by all except inferior surface of liver, common hepatic duct, cystic duct. So the answer will be cystic artery, which is actually a content of the Caloid's triangle. Question number 18, ureteric constrictions are at all sides except pelvic ureteric junction, lesser pelvis, ischial spine, urinary bladder. So you need to revise these constrictions of ureter. These are very important and often asked. So you know that there are minor calyces, then major calyces, then they form this renal pelvis. Now from this renal pelvis, this is ureter being formed. Ureter descends down like this. The length of ureter is 25 centimeters or 10 inches. Now when it descends down, it crosses this the brim, the margin of the true pelvis, the lesser pelvis. This is the pelvic brim, the upper margin of lesser pelvis. And this point is pelvi-ureteric junction. Now you know that here it is the urinary bladder being placed like this, let's say. And this urinary bladder inside has this muscle, the trigone. So this ureter, when it descends down into the lesser pelvis, that's a true pelvis, at the level of ischial spine, it will be crossed from above by the ductus deferens, the vas deferens in males. Otherwise, in females, it will be crossed by the round ligament of uterus. Then it approaches and enters this urinary bladder with an oblique course. So at its being an oblique course, it also has to traverse to the musculature of the urinary bladder. This is vas deferens in males and round ligament of uterus in females. Then this course is the intramural course, oblique course in the musculature of urinary bladder. Then finally here at this terminal point you find is an ostia opening. This is called the ureteric opening. So at this point also there will be constriction. So now you got to know that there are 5 normal constrictions in the course of ureter. One is the pelvi-ureteric junction is number 1. Then when it crosses this pelvic inlet, that is the brim of the lesser pelvis, and then it's by vas deferens or the round ligament of uterus, then it's the oblique intramural course, and then it's the opening, the ostia in the angles of the trigone where it opens into the bladder. So these are the 5 major constrictions of the ureter. You'll have to learn this because these questions are commonly asked in your Viva exams, theory exams, and in MCQ patterns also. So let's see the answers. Ureteric constrictions are at all sites except pelvi-ureteric junction, correct, lesser pelvis, ischial spine, urinary bladder wall. Answer you can mark here is ischial spine, although not a very good option to be ruled out because ischial spine is the same level where this vas deferens crosses the ureters. So answer here you can mark is ischial spine. And lesser pelvis is a big option. So they have to be precise here, writing that brim of lesser pelvis. Question number 19 is all structures are posterior relations of the cecum except appendix, psoas major, greater omentum, femoral nerve. So for this you need to revise this posterior relations of the cecum. Remember it's this iliac crest, and here you have is the pubic tubercle, and this was inguinal ligament. So this muscle coming from the posterior abdominal wall, and this muscle is a big muscle, it's a very powerful muscle, descends like this, arising from the transverse process of the lumbar vertebrae anteriorly. This muscle descends down like this to get attached on the lesser trochanter of femur, and while in its course, when it reaches the greater pelvis, it also gets contribution from this muscle iliacus. So together the two muscles, psoas major and iliacus, both of them join and they form iliopsoas to insert onto the lesser trochanter of femur. Then talking about this other relations you have is this common iliac which divides into external iliac and internal iliac arteries at the level of sacroiliac joint. Now from there, this external iliac artery, it continues down like this and will emerge now as femoral artery. So this is external iliac artery, this is femoral artery. Aligned to this. Talking about the nerves, one more artery, although there is one more artery, that descends down in front of psoas major, and this artery is the gonadal artery. Gonadal artery, ovarian or testicular artery. Now other relations are the nerves here. Obviously femoral vein also will be there. Veins I'm not drawing. So here this nerve descends, which this nerve actually descends in anterior relation to psoas major. Remember this. This is genitofemoral nerve. Then this thick nerve which emerges, runs between psoas major and iliacus. This nerve runs between psoas major and iliacus and passes below the midpoint of inguinal ligament. So this nerve is femoral nerve. There's one more nerve which actually is descending down here over to iliacus, and it actually crosses just in front of the anterior superior iliac spine or below the lateral end of inguinal ligament. This nerve is the lateral cutaneous nerve of thigh. This is the location of cecum. Cecum you will find is placed like this over here, and here it is this orifice, the iliocecal valve, and is this another orifice. From here, this appendix no doubt have a lot of positions, but the most common position of appendix is retrocecal. So it also will be behind to the cecum here. This valve, iliocecal valve, is also called Tulp's valve. This valve here at the opening of the appendix into the cecum, this is called valve of Gerlach's. So I hope you understood all of them. These are all the posterior relations of the cecum. So what they have asked is all the structures of posterior relations of cecum except appendix is there, psoas major is there, femoral nerve is there. Remember this greater omentum, which we call as the policeman of the intestine, policeman of the abdomen. It is like an apron which covers all the loops of the intestine from the front. So greater omentum will be in anterior relation to the cecum. So the answer here is greater omentum. Question number 20. Supports of the uterus are all except uterosacral ligament, broad ligament, Meckenroth's ligament, levatorani. Because it's a big topic, you need to learn them all. This is equally asked in obs-gynae exams as well. So you need to know about the supports of uterus. So let's talk about supports of uterus. So let me tell you, there are two types of supports. One are the primary supports, which have a definitive role in support of the uterus, and some are said to be the secondary supports, which actually do not have a very good role, very strong role in support of uterus, mainly by form of the fascial folds. So we focus upon the primary supports first. So let's talk about the primary supports of uterus. Now this primary support also has two types of supports. Active support are the muscular supports, which actually by contracting these muscles you can support the uterus in its position, and the other one is the fibromuscular. Active supports means on which it is resting, like the pelvic diaphragm, perineal body, then there is this distal urethral sphincter mechanism, which is also called the rhabdosphincter. The fibromuscular supports, it's also because of the positioning of the uterus that also helps in prevents of the prolapse. So one is the uterine axis. Then you have pubocervical ligament. Pubocervical ligament pulls this cervix anteriorly towards the pubis. Then you have uterosacral ligament. This ligament pulls the cervix posteriorly towards the sacrum. So you have a combating effort by these two ligaments. Then you have to maintain the cervix in position, like preventing its transverse movement. So there is this transverse cervical ligament of McIntosh. Then what makes the uterus anteverted in position? It is the round ligament of uterus. So these are the primary supports of the uterus, very important supports. Now let's talk about the secondary supports of liver. It's the fascial fold, It's the peritoneal fold. This uterus is sandwiched between the peritoneal folds from above and below, or you can say from front and behind. And those folds, when stretched laterally, that's called broad ligament. This broad ligament also provides a way of passage of the blood vessels and nerves to reach to the uterus. Then you have is vesico-uterine pouch. So this vesico-uterine pouch is a fold of peritoneum between bladder and the uterus, means anterior to the uterus. Similarly, behind to this uterus, there is recto-uterine, or some people call it as recto-vaginal pouch of Douglas. So these are simply peritoneal folds which have a negligible support or very doubtful support to the uterus. So let's see the choices here in your question. Supports of uterus are all except uterosacral ligament, a very powerful support. Broad ligament, not a powerful support. McInrod's ligament, a very powerful support. Levator ani is also a very active support to the uterus. So here you can, to select the best choice, right? So you can select broad ligament as the answer here. It also is a support to the uterus, but of negligible value. So these 20 questions have been done. Let's move further. Now for those who are appearing in this exams of this Rohilkhand University further, they can have a check on this question paper. This is part B of 40 marks. It was this question: describe right atrium of heart with its interior. This was of 15 marks. Then there were short notes on popliteal fossa and azygous vein, 5 marks each. There was this question, write short note on applied aspect of the lung with special mention on COVID-19 infection. This was also 5 marks. This is a clinical type question. A confused violent patient requires an urgent intramuscular injection of sedative. The nurse gives injection into the upper lateral quadrant of the buttocks. She chooses this side in order to prevent damage to which nerve? What is the root number of this nerve? Obviously, it's the sciatic nerve. Sciatic nerve has to be taken care while giving this intragluteal injections. And the root number, remember, this sciatic nerve actually is formed by 2 nerves. I'm drawing here the root number so you can remember the sciatic nerve. This is L4, L5, S1, S2, S3, S4. These are the ventral primary rami of these spinal nerves of one side. And here I'm drawing is the ventral division of these rami and the dorsal division of these rami on this side. So from ventral division of L4, L5, S1, S2, S3, the nerve form here, it is called tibial nerve. Similarly, from the dorsal divisions of these ventral primary rami arising from L4, L5, S1, S2, the nerve formed is called common peroneal nerve. So if you tie both these nerves or cover them with a sellotape together like this with a common epineurium, now this nerve is called sciatic nerve. So remember that sciatic nerve is a combination of tibial nerve and common peroneal nerve. Tibial component arises from the ventral division L4 to S3. Common peroneal nerve arises from the dorsal division L4 to S2. So you can, in case if it was this question for you, you can describe as I have mentioned here, because they've asked is the root value. So root value is actually from L4, L5, S1, S2, S3. But S3 is not included in the dorsal division that is forming CPN. So the better way of expressing is drawing the same diagram which I have mentioned here. The question was, write briefly about 2.5 marks, 2 question, ligamentum patelli and intercostal spaces. Part C, 40 marks. It was question number 1 was, describe right side kidney in the following headings with diagrams, coverings of the kidney, surface of the kidney with the relations, blood supply of the kidney, development of the kidney. This was of 15 marks, a long question. Then there were 2 short notes on supports of uterus. See, I have just described the supports of uterus for you in this MCQ portion, and vermiform appendix. These were of 5 marks question. Then there was this question on anal canal. Write short note and applied aspect of anal canal. This was to include the anal prolapse and the hemorrhoid, the piles and varices and all. Anal fistula, anal fissures, lot many things. Now question number 4 is the clinical type of question. During an operation for bleeding duodenal ulcer, the surgeon accidentally damages the structure posterior to the epiploic foramen with the result that the operative field immediately fills with blood. What structure is likely to be have damaged? So you know that epiploic foramen is immediately posteriorly related to inferior vena cava. I'm mentioning it here also for you because this question keep about epiploic foramen is also very commonly asked. So let's presume this is T11, this is T12 and this is L1. And this will be the position of foramen epiploicum. That is a channel to communicate between greater and lesser sac. And you know that foramen epiploicum is communication or a space from below to the lower free edge of this lesser omentum, and the lower free edge of the lesser omentum is formed by the hepatoduodenal ligament. So let's see here, this is the first part of the duodenum here. This is the first part of the duodenum and this will be covered by this lesser omentum like this. It actually is the hepatoduodenal ligament which forms the lower free margin of the lesser omentum. So what will be the structures passing here? Remember, the most anterior will be the bile duct, then you have is the hepatic artery, and then you have is the portal vein. So this formula of DAV, anterior to posterior, is very important to remember. So these are the structures which are in anterior relation to the foramen epiploicum. Now what lies just above to the foramen epiploicum? Here you will find is this lobe of liver, and that is the caudate lobe with the caudate process. Caudate process. As I already told you, what lies immediately behind to this foramen epiploicum is inferior vena cava. And behind to that, at this level of T12 vertebrae, you also find is this right suprarenal gland. Right suprarenal gland. And if they ask what is the vertebral level, so remember T12 is the vertebral level of foramen epiploicum. Inferiorly, if they ask now the same duodenum, the first part of the duodenum and this vessels, they are actually also in inferior relation as well, because this I have drawn is a little bit not very proportionate. This should be actually like this, right? So duodenum should actually be placed here a little more inferiorly, so you've got a better idea. This also lies antero-inferior to the foramen epiploicum. So I hope you've understood what structure is likely to be have damage, that is inferior vena cava. And because they have said that this is operative field is quickly filled with blood. Then 2.5 marks, 2 questions, levator ani and inguinal canal and its contents. And that was all.